friends. Welcome. I am Dr. Harvinder Singh, creator of Psychiatry Education Forum Academy. So the video topic is how to diagnose the physical dependency on benzodiazepine, prescription benzodiazepine here. And this following video is a short section from our recently released course on evidence-based benzodiazepine tapering, which is a 2-hour course where I have summarized the 2025 ASAM guidelines page to page. It's like 200-page guidelines, so I have summarized that in 2 hours. I know it looks long, but it's not. And this following video will focus on that. One of the topic, which is how will you diagnose somebody who is physically dependent so that you can decide between either doing a slow taper or sudden discontinuation. But if you're interested in learning more, please go to psychiatryeducationforum.com/psychiatrystudio. But I will see you at the end of the video to talk more about our course. But let's start our session right now. So going back to the flowchart, here risk outweighs benefit. So you decide, okay, taper is needed, but is patient likely to be physically dependent? Let's try to answer this question now. Now here in this section, we will evaluate the physical dependency to decide between tapering versus discontinuation. Discontinuation is like fast taper or sudden discontinuation. But obviously, with physical dependency, tapering is the first line. Now with the tapering versus discontinuation, this is a table. I will recommend this will be the second table. If you want to print this presentation slide, please print this second table. So in this guideline, there are 3 things, 1, 2, and 3, which I will talk here. These 3 things you need to look for to decide if the risk of physical dependency is high. Thereby, the risk of withdrawal will be high. And these 3 things are, first, what is the duration of their benzodiazepine use? How long they are using it for? Second, frequency. How many days of the week they are using it for? And what is the total daily benzodiazepine dose? And I will talk about that in a few minutes again, how you measure that. And these 3 will give you the risk of clinically significant withdrawal risk for patients. Now, and the committee, you can see CGC is the committee. They have agreed that these factors were the most salient in determining the physical dependency risk. So let's go over them very quickly. Let's say duration of benzodiazepine use is any. It doesn't matter 1 day, 1 month, 1 year. But the frequency of benzodiazepine use is less than 3 days per week. And total benzodiazepine use was any. Then the risk of dependency withdrawal risk is rare. But if the duration of benzodiazepine use is less than 1 month and the frequency is more than 4 days per week and total benzodiazepine dose is any, like it doesn't matter which dose, even then the risk is lower, but there is possibility. But as soon as the duration goes 1 to 3 months, frequency goes more than 4 days per week, and the total daily benzodiazepine dose is low. I'll talk about what low, moderate, and everything is in a minute. But then also the risk is lower, but the possibility is there. And then when the duration goes to same 1 to 3 months, frequency of benzodiazepine use is 4 days per week or more, and the total benzodiazepine dose is moderate to high, that's when it's definite yes with greater risk with increasing dose and duration. So it looks like this is one of the important one. Out of these 3, the total benzodiazepine usage, keep an eye on that. Because here you can see how it was already more than half days of the week here. And the duration was already 1 to 3 months. But as soon as it touched this one, the risk goes up. And the last is if the duration goes more than 3 months and the frequency is more than 4 days per week, and total benzodiazepine daily dose is any, the risk is still yes, with greater risk with increasing dose and duration. So the question comes to the mind is, so I have actually done these in these blue color to keep an eye on the risk factors. Like, this is just my personal viewpoint on this right now. So as soon as the day goes 4 days or more per week usage, then your risk thinking should go up. And then you look at how long the person is using for. As soon as it's more than 1 month, then you look at the total benzodiazepine dosage. If there is low, moderate, high, moderate to high will increase the risk of withdrawal. Now, the question is, what is the total daily benzodiazepine dosage? What does that mean? What is low? What is moderate? What is high? Let's understand that briefly. Now, let me go back. So there are 3 classes here: low benzodiazepine daily dose, moderate benzodiazepine daily dose, and high benzodiazepine daily dose. They are based on the diazepam equivalence. So if the medicine is 10 milligram or less than diazepam equivalent, that's a low daily dose. And if it is 10 to 15 diazepam equivalents, that's moderate. And as soon as it crosses 15 diazepam equivalents, it's high. And you will now ask, what is diazepam equivalence? How can I convert that diazepam to other benzodiazepine? Well, the guidelines have actually used this table. You all know Ashton manual, right? I used to use that a lot. This was done in 2002. I think it was not updated. So Ashton manual, see, diazepam 10 milligram is on top, and everything is an equivalent dose to that 10 milligram of diazepam. But the VA DOD guidelines published in 2021 is the most recent one. You can use either of that, but there are certain variability. You can see how the VA dose conversion is a little bit more, right? How for alprazolam, it's like 1 milligram for VA DOD guidelines and 0.5 for Ashton manual. Even for clonazepam, it almost doubles if you look at it, 0.5 to 1. For some, it remains same, like lorazepam, 1 milligram goes to 2 milligram. Now, use this for the dose conversion, but this is a really important thing. These dose conversion that we are talking about, these are not based on any research done in the lab or anything, but these were based on what patients have reported when they did the dose conversion for symptoms management. So this is a patient report. And so that's why it's so vital to include your patient experience when you're converting these agents. And actually, I didn't know about this. This was a new learning for me, that this is all patient report based dose conversions. So that's why, that considering that mutual patient decision making with your patient is so vital part of these guidelines. And for that reason, some patient may require higher doses, some patient may require low doses depending on what's happening. So this was something you can even print and keep it on the side if you want to use this as a base for your dose conversion between medication or risk stratification. Thanks for watching this video, friends. Just bear with me for a few more seconds. I just want to go over this course that was created in Psychiatry Education Forum Academy. So this is a 2-hour course where I have summarized the 2025 ASAM guidelines on how to use the question of whether to taper benzodiazepine or not from the evidence-based standpoint. And this is based on this recently released guideline by American Society of Addiction Medicine, ASAM. And I have divided this into 4 sections, 4 lectures, total 2 hours long. This first section is a very basic overview of how to assess risk and benefit, how to decide between tapering and discontinuation. And this video is actually this section that you just saw. And then you understand the importance of shared decision making with your patients and then assessing the level of care. So this is the building block, this first section. And then based on that, we will go to our second section. This is the longest section we have. This will talk about the basics of tapering process. So how to begin the taper, how to proceed, how this is not one size fit all, what all to do in terms of ongoing monitoring when you are tapering, the role of longer acting benzodiazepine, how to manage various levels of withdrawal symptoms, how to assess and manage seizure risk, and what to do as you're approaching the discontinuation. And then third section is in the role of adjunctive strategies and complication management. Here I have talked about role of adjunctive intervention, behavioral intervention, sleep hygiene, what pharmacological agents should be considered, if they should be considered for benzodiazepine tapering, how to manage a severe or complicated withdrawal, the role of phenobarbital taper, which medicines to avoid for taper, and something called protracted benzodiazepine withdrawal. We'll talk about that here. And the last section is on special population, where we will discuss what to do when patient is prescribed both benzodiazepine and opioids. And then for patients with benzodiazepine use disorder or other substance use disorders, patient with co-occurring psychiatric disorders, and then in older adults and pregnancy and lactation. So this is the basic overview, but please go to psychiatryeducationforum.com/psychiatry studio. You can see it's free currently for Academy members. It will be free for Academy members moving forward as well. But if you're not Academy member, you can either buy this for a very, very cheap price, one-time price, or you can consider subscribing to our Academy. But thanks again for listening to me. This is Dr. Singh signing off. I will see you in our next video. You all take care and bye for now. Thank you.